Hello once again, future doctors. To continue with our learnings about the respiratory critical care, we will tackle now the acute respiratory distress syndrome. So it is a clinical syndrome of severe dyspnea of rapid onset, hypoxemia, and diffuse pulmonary infiltrates leading to respiratory failure. The annual incidence of ARDS is estimated to be as high as 60 per 100,000 population, and 10% of all ICU admissions involve patients with ARDS. So ARDS, by the Berlin definition, it is subdivided into three categories or three severities based on the degree of hypoxemia. If the PF ratio, that's the ratio of the arterial oxygen over that of the fraction of inspired oxygen, is between 201 to 300 millimeters mercury, then we are dealing with mild ARDS. The moderate ARDS is when you get a PF ratio of 101 to 200 millimeters mercury. Worse to that is the severe ARDS. Once the PF ratio falls to 100 or lower, then we are dealing with severe ARDS. So ARDS, being acute in onset, should happen within 1 week of a clinical insult or new or worsening respiratory symptoms. And the chest radiograph would show us the bilateral opacities occupying more than 2/3 of the lung, consistent with pulmonary edema, not fully explained by effusion, lobar or lung collapse, or nodules. And the absence of left atrial hypertension that would produce hydrostatic edema is not demonstrated. Proof of this is when you do your echocardiography that could rule out the hydrostatic edema. So why does ARDS happen? It results from diffuse lung injury from many underlying medical or surgical insults. So majority, of course, of ARDS is being caused by the direct cause would be pneumonia or the indirect effect of sepsis. Now, the other causes of direct lung injury is aspiration of gastric contents, pulmonary contusion, near drowning, and toxic inhalation injury. Indirect lung injury, on the other hand, as earlier mentioned, is mostly from sepsis. Trauma could also produce indirect lung injury if it involves multiple bone fractures, flail chest, head trauma, and burns. Another reason for ARDS could be the giving of multiple transfusions, producing your TRALI. Drug overdose could lead to ARDS, pancreatitis, and post-cardiopulmonary bypass. The clinical course on pathophysiology of ARDS is subdivided into three phases, or it is marked by three phases. Phase 1 being the exudative phase, followed by the proliferative phase and the fibrotic phase. So from day 0 up to day 6, that's your exudative phase. Edema formation is notable here with the neutrophil-rich leukocytic infiltration of the lungs and the subsequent formation of the hyaline membranes from diffuse alveolar damage. Now, counting from day 7 to day 14, the proliferative phase ensues with prominent interstitial inflammation and early fibrotic changes. Approximately 3 weeks after the initial pulmonary injury, most patients recover. However, some patients enter the fibrotic phase with substantial fibrosis and bullae formation. So the first phase is the exudative phase. There's filling of the alveolar sacs. The endothelial cells, the capillary endothelial cells and type 1 monocytes are injured. So there is now the loss of the normally tight alveolar barrier to fluid and macromolecules, such that edema fluid, rich in protein, accumulates in the interstitium and the alveolar spaces. So you see all the white here, covering the interstitium and the alveolar spaces. And there's also an increase in the pro-inflammatory cytokines, leading to recruitment of leukocytes or the neutrophils into the pulmonary interstitium and alveoli. So this encompasses the first 7 days of illness after exposure to a precipitating ARDS risk factor. So this figure shows us a representative AP view of the exudative phase of ARDS. See the bilateral opacities consistent with pulmonary edema that can be difficult to distinguish from a left ventricular failure. And now taking a cut from these bilateral infiltrates, the CT scan would look like this. You will be able to observe that the alveolar edema is worse on the dependent portion of the lungs, and there is a relative sparing of the other portions of the lungs. So the atelectasis and the alveolar edema is more pronounced in the dependent portion of the lungs. Now, the exudative phase is marked by a collapse of a large section of the dependent lung, which could contribute to decreased lung compliance. Here, what happens would be the mechanism of hypoxemia is the intrapulmonary shunting, such that the patient would have an increased work of breathing, and eventually the patient would begin to develop dyspnea. The pathophysiologic alteration in the alveolar spaces are exacerbated by microvascular occlusion that results in reductions in pulmonary arterial blood flow to the ventilated portions of the lung. So in effect, you have two problems here. You have the shunt that happens because of the flooding of the alveolar sacs, and you have an increase in the dead space. So you have a ventilatory problem because blood flow could no longer go through the open air sacs because of microvascular occlusion. So the exudative phase, as mentioned earlier again, happens in the first 7 days of illness, and the chest x-ray would now show the opacities consistent with pulmonary edema involving at least 3/4 of the lung fields. After the exudative phase, the patient goes on to the proliferative phase, and this usually would last from day 7 to day 21. It is at this phase that most patients recover and are liberated from mechanical ventilation. However, despite improvement, many patients still experience dyspnea, tachypnea, and hypoxemia. And some patients would even develop progressive lung injury and early changes of pulmonary fibrosis. Histologically, the first signs of resolution are often evident in the proliferative phase. We could see now the initiation of lung repair, the organization of alveolar exudates, and the shift from neutrophil to lymphocyte predominant infiltrates. If the patient have not recovered in the proliferative phase, he will go into the fibrotic phase. It has been expected that lung function recovery happens 3 to 4 weeks after initial pulmonary injury. But for those who go into fibrotic phase, they would eventually require long-term support on mechanical ventilators and supplemental oxygen. In the fibrotic phase, the alveolar edema and the inflammatory exudates of the earlier phases are now converted to extensive alveolar duct and interstitial fibrosis. Emphysema-like changes happens because there is marked disruption of the acinar architecture. There is now intimal fibroproliferation in the pulmonary microcirculation, causing progressive vascular occlusion and eventually pulmonary hypertension. With the emphysema-like changes, the patient is now at increased risk of pneumothorax. There would be reduction in the lung compliance because of the fibrosis and increase in the pulmonary dead space. So if a patient survives the fibrotic phase, you would expect increased morbidity. So this beautiful picture shows us the other half of a normal alveoli, where the cells are intact, the type 1 cell, the bronchial cells, and the basement membrane is intact. The surfactant layer is there protecting the alveoli. And on the other half, you would now see the disruption of the bronchial epithelium. Type 1 cells become apoptotic, and the surfactant has become inactivated, such that fluids could now leak through the initially intact basement membrane. And because it's no longer leak-proof, anything could come in. The denuded basement membrane could allow the neutrophils, the macrophages, the red blood cells to go inside the alveoli. There may be some sparse intact type 2 cells, but because of this denudation, hyaline membrane formation already happens in the acute stage of our ARDS. And then there's also widening of the interstitium. This is the uninjured interstitium. See how thin they are? But in ARDS, this is significantly widened. And because there's leaking in the capillary supplying the affected alveoli, some of the platelets, blood products, the neutrophils, they will migrate from the capillaries to the interstitium. Some would go into the alveoli, where the activated neutrophils would produce the leukotrienes, the platelet activating factor, the oxidants, proteases, producing more damage in the tissue. And in the hyaline membrane, fibroblasts already get in, paving the way for fibrosis eventually. Procollagen already in the interstitium. And then the activated alveolar macrophages are now producing your inflammatory cytokines. They become pro-inflammatory. So the inflammatory cytokines produced are your interleukin 6, interleukin 8, the tumor necrosis factor alpha. So this is how the ARDS lung would look like. And it's a very beautiful picture. I hope you would take a moment to really digest what is happening in the ARDS lung. So understanding now what is going on in the lung of the patient who is suffering from acute respiratory distress syndrome, we should be guided by the following general principles when we treat this set of patients. We have to recognize and treat the underlying medical and surgical disorder. We should minimize unnecessary procedures and their concomitant complications. We should follow standardized bundled care in the approach of our ICU patients with ARDS, and this would now include prophylaxis against venous thromboembolism, against gastrointestinal bleeding, aspiration, excessive sedation, and others. And there should be a prompt recognition. We should be on the lookout always for a possible nosocomial infection. And there should be provision of adequate nutrition via enteral route when feasible. because what is almost always unrealized is this patients are under so much stress that they would eventually consume the muscles just to fuel the day-to-day processes. So how do we manage the mechanical ventilators of our ARDS patients? Again, we aim to minimize ventilator-induced lung injury, minimize atelectrauma, the prevention of alveolar collapse, and eventually, probably, if oxygenation will not improve, institute prone positioning. So how do we minimize ventilator-induced lung injury? There are actually two principal mechanisms of ventilator-induced lung injury. It's the volutrauma and the atelectrauma. Volutrauma happens when there is repeated alveolar overdistension, and this happens if you give a high tidal volume. Atelectrauma, on the other hand, happens if there is recurrent alveolar collapse. So if you do not give a positive and expiratory pressure, every time the patient exhales, the alveoli would collapse. All the air would go out. And if that happens repeatedly, atelectrauma ensues. To prevent these things, to minimize these kinds of injury, the Ards net instituted by the National Institutes of Health have recommended a low tidal volume approach, low being 6 mils per kilogram of predicted body weight. And studies have shown that with this approach, there is a significant decrease in the mortality rate in our ARDS patients. And not just the tidal volume of 6 mils per kilogram of predicted body weight is instituted, we should also target plateau pressure of less than 30 centimeters water. To minimize atelectrauma, we prevent alveolar collapse. And this is achieved by the giving of positive and expiratory pressure. So we adjust PEEP to minimize FiO2 while providing adequate oxygenation without causing alveolar overdistension. We have to distend the alveoli that, remember, is being flooded by interstitial fluid or by the lack of surfactant, so that it is being filled up with fluid now. So that fluid has to be displaced by enough pressure and enough air, but not too much of this pressure or air should go out so that the lung would not collapse. There is no consensus yet on the optimal method to set PEEP. However, it should be guided by our understanding of the pressure volume curve of our respiratory system, as discussed in the initial meeting. The setting of PEEP at the lower inflection point of the pressure volume curve would maximize the respiratory system compliance. If you do not set the PEEP, or you set the PEEP below the lower inflection point, then you should remember that the alveoli at below the lower inflection point collapses, so it will not work. The other approach to try to improve oxygenation for our patients, so in a way it's a form of treatment, is to do prone positioning. Through the years, a lot of the trials have demonstrated that even if prone positioning improves oxygenation, it did not actually improve mortality. But there were recent trials that have shown a significant reduction in the 28-day mortality with prone positioning. So from 32% mortality without prone positioning, this has improved to 16% mortality only. However, prone positioning requires a critical care team that is experienced in proning, because this entails its own set of hazards. When every time you reposition the patient, you have that risk of accidental endotracheal extubation. There could be the loss of your central venous catheters, and some patients might fall, producing orthopedic injury or too prolonged a time in the prone position would actually produce nerve injuries along the neck. So the other strategies in mechanical ventilation, we could do some recruitment maneuvers. The underlying principle here is that we want to recruit as much atelectatic lung as possible to increase the PEEP to high level, by increasing the PEEP to high levels and thereby increasing oxygenation. However, you should understand that in the presence of atelectasis and consolidation, the lungs that are already collapsed may not be recruitable anymore, and you will just be over distending the alveoli that has already been recruited. The alternative modes of mechanical ventilation, like the airway pressure release ventilation and high frequency oscillatory ventilation, may help our ARDS patient. And if everything else fails, then we replace the function of the lung in the same manner that we could replace the function of the kidney with the dialysis. The lung replacement therapy is referred to as extracorporeal membrane oxygenation, or ECMO, which is very popular nowadays in the pandemic. Now, another approach in the management of ARDS patient is how we manage the fluids. We should remember to maintain a low left atrial filling pressure to minimize pulmonary edema. So this would prevent further decrements in the arterial oxygenation and lung compliance. This would improve pulmonary mechanics and shorten the ICU stay and the duration of mechanical ventilation. So aggressive attempts to reduce left atrial filling pressures with fluid restriction and diuretics should be an important aspect of ARDS management. Now, in severe ARDS, sedation alone may be inadequate for the patient ventilatory synchrony. That is what is required for the lung protective ventilation, so that early neuromuscular blockade with cisatracurium may be beneficial for the patient. But just give this for 2 days, and this way we will increase survival but decrease the likelihood of the post-paralytic syndrome. And in the long run, ventilator-free days would be more. And ever since ARDS has been closely studied, glucocorticoids, the role of glucocorticoids has always been in question. There have been several attempts to treat both early and late ARDS with the goal of reducing potentially deleterious pulmonary inflammation. Few studies have shown any significant mortality benefit, and current evidence does not support its routine use in ARDS. So, evidence-based recommendations for ARDS therapies. If you're doing mechanical ventilation, low tidal volume has a grade A recommendation. The rest have grades B, C, and D. Grade B for minimizing the left atrial filling pressure, maintaining high PEEP or open lung, prone positioning warrants a grade B recommendation, ECMO, and the early neuromuscular blockade. So you will not go wrong if you would choose to paralyze your patient. So in the algorithm for the initial management of ARDS, you initiate the volume pressure limited ventilation with a goal of giving only 6 mils per kilogram predicted by the weight of your tidal volume, Plateau pressure of maximum of 30 centimeters water, and respiratory rate of at most 35 beats per minute only. And the aim of oxygenation should be to achieve a saturation of 88 to 95%, while giving an FiO2 of 60% only. And we should minimize acidosis. pH should be more than or equal to 7.3 with an RR of at the most 35 beats per minute, breaths per minute. And then diuresis, to maintain a MAP of more than equal to 65 millimeters mercury at the same time avoiding hypoperfusion to vital organs. So what's the prognosis of our ARDS patients? Mortality actually, based on the report from the large observational study to understand the global impact of severe acute respiratory failure or the lung safe trial, they were able to demonstrate hospital mortality estimates. For mild ARDS, mortality rate is at 34.9%, moderate ARDS at 40.3%, and worse mortality prediction for the severe ARDS at 46.1%. The mortality in ARDS is largely attributable to non-pulmonary causes, with sepsis and non-pulmonary organ failure accounting for more than 80% of deaths. So the major risk factors for the non-pulmonary cause of death is advancing age. If a patient is more than 75 years old, it has a 60% mortality compared to younger ones who are less than 45 years old, whose mortality rate is only 20%. Patients older than 60 years old with ARDS from sepsis have a threefold higher mortality risk than those who are younger than 60 years old. The other risk factors are the presence of a chronic medical illness like chronic liver disease, cirrhosis, chronic alcohol abuse, and chronic immunosuppression. ARDS arising from direct lung injury, that's from pneumonia, pulmonary contusion, and aspiration, are twice as likely to die as those from ARDS arising from other insults to the lung. And the increasing severity of ARDS, based on the Berlin definition, would also dictate mortality. So how are the patients who eventually recover from ARDS? They usually recover at their maximal lung function within 6 months. And 1 year after extubation, more than 1/3 have normal spirometry and diffusion capacity. However, the sad news is that even 5 years after ARDS, there could still be exercise limitation and decreased physical quality of life despite normal or near normal pulmonary function. That ends now the lecture for ARDS, and for the next topic, read ahead on mechanical ventilation. Thank you very much for listening.